Welcome to the official YouTube channel of the Indian Society of Toxicology. We meet once again, this time for a unique kind of presentation on mushroom poisoning. But first, greetings from the Poison Control Center of Amrita Institute of Medical Sciences, Cochin, Kerala. We have been in existence for more than 17 years. We have a 24-hour poison information service and an accredited clinical analytical toxicology laboratory. You can contact us at any time on any issue relating to poisons and poisoning. In today's presentation, which has been prepared by Professor Somnath Das of Kolkata and presented by yours truly, we'll be looking at mushroom poisoning, something which has not been paid much attention, especially in India, because admittedly it's not very common, but that doesn't mean that we should be complacent. Mushroom poisoning is also called Mycetism, so don't get confused. Let us start by first looking at some statistics. The 10-year period from 2001 to 2011 saw more than 83,000 mushroom ingestions being reported by the US poison control centers. So as you can see, mushroom poisoning is fairly common over there and some other countries in Europe. Of the reported cases, it was a little disturbing to know that many involved children, in fact nearly 78%, and children under the age of 6 years accounted for nearly 60% of the cases. And of all reported exposures, only about 5% could be identified with certainty as to the species involved, the species of mushroom. Only about 185 in total. So that means identification is always going to be difficult, especially with regard to species. We'll talk a little bit more in detail with regard to that later. Even mortality, if you look at, it is higher in children and the elderly as compared to young adults. So one has to be very careful when you come across mushroom poisoning in a child. And a report from the North American Mycological Association, NAMA, case registry suggests that mushroom toxins may be transferred to infants through mother's milk, and that also has to be borne in mind. Some general information on mushrooms and mushroom poisoning. Mushroom foraging, that is hunting for wild mushrooms, which leads to a higher incidence of mushroom poisoning, is a common practice in some parts of Russia, Asia and Europe. Not all that common in India, but yes, it does happen from time to time. We come across somebody who forages for mushrooms in the wild and cooks and eats and gets into problems. Accurate figures regarding incidents of mushroom toxicity are unfortunately difficult to obtain. But outbreaks of severe mushroom poisoning have occurred in Europe, Russia, Middle East and Far East. And even India has not been spared. For instance, in April 2008, an outbreak of mushroom poisoning happened in the upper Assam area, which claimed more than 30 lives. So as I said, even though mushroom poisoning may not be very common in India, we cannot be complacent, and cases do get reported from time to time. Of the more than 2,000 species of mushroom known worldwide, about 300 species are encountered in India, of which about 150 species are definitely edible, whereas remaining may or may not be toxic. A few are certainly very toxic, and we'll look at those in detail in this presentation. But before that, let us refresh our high school memory with regard to how a mushroom looks like. This figure gives you the essential information as far as the different parts of a mushroom is concerned. The mushroom has a stalk, also called a stipe, with a cap on top, and under the cap, the undersurface, you have gills, where you have pores that contain spores. There's also sometimes a ring around the stalk and a volva at the base of the mushroom, though these are not always present. So these are the essential features or the nomenclature with regard to mushroom that you should be familiar with. Now coming to the various kinds of toxic mushrooms or poisonous mushrooms. First of all, you have the cyclopeptide containing mushrooms, very common, and some of the deadliest mushroom poisoning cases involve these species, of which the most important is Amanita phalloides, seen in India also. Contains toxins which are very powerful, which are quite potent, like amatoxin, phallotoxin and virotoxin. We'll come to the details a little bit later, but let's look at the other categories of mushrooms. The second category, ibotenic acid and muscimol containing mushrooms. Very important example again, Amanita muscaria. Look at the cap, scarlet red in color with flecks of white. Very distinctive, very dangerous indeed. Then you have alinic nor-leucine containing mushrooms, of which the important example is Amanita smithiana. Gyrometrin containing mushrooms which have a characteristic brain-like appearance, as you can see in the image, belong to Gyrometra species. Then you have psilocybin containing mushrooms, often called magic mushrooms because they cause hallucinations, belonging to psilocybin species. They are quite common in some parts of India, especially in the Kodaikanal region of Tamil Nadu. We'll discuss the details when we take up hallucinogenic drugs in another session. Then there is the muscarinic containing mushrooms, of which the important species are psilocybin, coprin containing mushrooms belonging to coprinus species, and then GI toxin containing mushrooms like the jack-o'-lantern, which is poisonous, not to be confused with the chanterelle, which is edible. They look quite similar, isn't it, if you look at the images. But if you look at the undersurface of the cap, you will see that there is a difference in the gills. The chanterelle does not really have true gills, folds more than gills, whereas the jack-o'-lantern certainly has very distinctive kinds of gills. And this being Halloween season, let me wish you all happy Halloween, because you see there is a different kind of jack-o'-lantern during this festival, which is celebrated in some parts of the world, especially the US and some parts of Europe. You have these, pumpkins which are scooped out, and then a face is carved into the, pumpkin with lighted candle being placed inside, and these are then placed outside, doorsteps in houses. And there are a lot of tradition and other things associated with Halloween. We cannot go into the details, but that is also called a jack-o'-lantern, that this kind of scooped out pumpkin with the light placed inside and a face carved into the pumpkin. I think you can enjoy Halloween if you would like, whichever part of the world you are in, but make sure that he doesn't come home. This is an iconic film. The poster from that film, Halloween, made way back in 1978, which features a serial killer who comes hunting during Halloween night. And this kind of jack-o'-lantern that is featured on the poster is pretty eerie, isn't it? You should be watching the film if you like horror. It's pretty interesting, and yes, more details I can give maybe on some other platform. I'm a big fan of horror films, by the way. But then we are digressing, so let's get back to mushrooms. We have this category called orelinin and orellanin. It's a little confusing, is it? One is spelled O-R-E-L-L-A-N-I-N-E, so that is orelinin. Then you have O-R-E-L-L-I-N-I-N-E, orellinin. Difficult, doesn't matter, as long as you know that the species is Cortinarius. So this kind of mushroom, again, not very common in India, but you can remember the species name at least. And then you have other esoteric types like rhabdomyolysis associated mushrooms, erythromelalgia, acromelic acid containing mushrooms, polyporic acid containing mushrooms which can cause encephalopathy, and mushrooms associated with immune mediated hemolytic anemia. But these are pretty unusual types. This particular image shows you one of the commonest edible varieties of mushroom, the so-called puffball mushroom. Unfortunately, they can sometimes resemble the immature Amanita mushroom, which is deadly poisonous, and we will be discussing in detail about Amanita species of mushrooms. I have already mentioned the toxins which are present in such mushrooms, the so-called cyclopeptide toxins. There are three varieties: amatoxins, phallotoxins, and virotoxins. Amatoxins, you have amanitin, you have subcategories like alpha, beta, gamma, delta, epsilon, delayed action but very powerful action indeed. And then there are certain other kinds of amatoxins listed here which are not all that important to remember. Then you have phallotoxins, of which the most important is phalloidin, quite rapid in action and quite powerful. And there are related other toxins also which are listed here, again not all that important to remember, just listing it for the sake of completion. And then you also have virotoxins, of which 5 types have been isolated. So for all practical purposes, remember the 3 main categories of cyclopeptide toxins and Amanita mushrooms: amatoxins, phallotoxins, and virotoxins. They are very commonly associated with Amanita phalloides poisoning. With regard to phalloidin, mechanism of action is said to be interruption of actin polymerization and therefore disruption of cell membrane function, with increased permeability of plasma membrane of hepatocytes especially by binding to actin F of plasma membrane. Phalloidin fortunately has limited absorption, therefore toxicity, but that's not the case with amanitin, which is much more potent than phalloidin and can cause significant renal, hepatic and brain damage. Alpha amanitin in particular is cytotoxic, interfering with RNA polymerase II, preventing transcription of DNA, and target organs are those which have high turnover of cells like GI epithelium, hepatocytes and renal cells. So the most important toxin is certainly amanitin. Coming to the phases of amatoxin poisoning, which you see with regard to Amanita phalloides especially, there are 4 phases. And it is important to remember these. The first phase is so-called lag phase, which can last up to 24 hours and is asymptomatic. The person may not realize when the symptoms set in that actually it is related to the mushrooms that he ate because of this lag phase. Phase 2, gastrointestinal phase, 6 to 24 hours after ingestion, with nausea, vomiting, crampy abdominal pain, and there can be severe secretory diarrhea. Then you have the apparent convalescence phase, 1 to 3 days, when the person thinks that he has recovered, and that can be quite tragic. While he is asymptomatic during this phase, during the terminal part of the 3rd phase, there can be hepatic and renal dysfunction, and once that sets in, which heralds the onset of the 4th phase, acute liver failure becomes imminent, which is seen in 4 to 9 days. There can also be renal failure in addition to hepatic failure. There can also be multi-organ failure, and death can occur. In fact, mortalities can extend up to 20%. So you can see here that mushroom poisoning, especially Amanita phalloides, can be pretty treacherous. And a person who has consumed that mushroom may not really realize the dangers, and that is why mortality is not unusual with Amanita phalloides mushroom ingestion. There can be other clinical features also, like hypoglycemia, cardiovascular collapse, coagulopathy, seizures, respiratory distress syndrome, and delayed polyneuropathy. So it's a kind of multi-organ picture. And with regard to renal failure, there is a characteristic bimodal peak that you see in Amanita poisoning, with phase 2 showing indirect, kind of renal problems due to dehydration and decreased renal perfusion, whereas phase 4 there is direct renal toxicity. And coming to the diagnosis, you should be in a position to recognize the toxidrome by evaluating the signs and symptoms, and take careful history from the patient and bystanders, assess everything thoroughly and carefully, look at the circumstantial evidence, especially by way of ingestion of mushrooms. But even in the absence of these diagnoses, you cannot rule out altogether. You can only say it can be still probable. Also in the case of mushroom, if it is present or remaining food, you can get that identified by an experienced mycologist, somebody who's an expert in fungi. You can, get the mushroom if it is available, examine and, try to deduce the species involved. You can go for laboratory investigations, the routine biochemistries. You can also go for toxicological evaluation. We'll come to that in a moment. But even in the absence of these, again, please remember, diagnosis you cannot rule out altogether. With regard to pre-medical action, before you actually start treatment, you have to record the following data: the time of ingestion, the time of first evidence of symptoms, and if you have a sample of the food or mushroom, then you have to preserve it in dry paper bag for future identification. And even if you do not have that, always keep a detailed note regarding the morphology of the mushroom if you have not preserved that. And certainly see to it that anybody who has taken mushroom in the last 24 hours does not take alcohol, because that can potentiate the toxicity of mushrooms like amanita and so many other kinds of toxic mushrooms. Identification of the mushroom, yes, gross appearance if you are a mycologist and an experienced one at that. Otherwise, don't attempt identification. There can be a lot of pitfalls, and microscopy can also be undertaken by an experienced mycologist. There is something called the acid fuchsin stain, which gives a vivid red coloration under the microscope. And then of course we have analytical toxicology, which we'll come to in a moment. But first, the grading of manifestations. There is a severity score that is given on this slide. There are 4 grades of severity of mushroom poisoning, especially Amanita phalloides. First grade, or grade 1, just gastrointestinal upset, no renal or hepatic derangement, easily managed by symptomatic treatment. Grade 2, all signs of intoxication present with mild to moderate rise in transaminases. Symptomatic treatment again usually suffices. Grade 3 is a dangerous grade, hepatopathy and coagulopathy with transaminitis. You can divide this into 3A and 3B. 3A with nil to mild bilirubin rise, whereas 3B is steep and continuous bilirubin rise. In such a case, you have to shift the patient to a liver transplant center for possible liver transplantation. Grade 4, steep rise in transaminase, bilirubin with renal damage, severe coagulopathy, mortality is very high, liver transplantation may not work. You'll have to manage to the best possible extent in ICU. So remember these 4 grades of severity of mushroom poisoning, especially relating to Amanita mushrooms, that is Amanita phalloides. I talked about toxicological tests. These are 2 tests which are very important: Mycetism test and Melzer test. We'll come to the details. Don't forget the other routine tests also, like complete blood count, sugar and electrolytes, liver function test, renal function test, and coagulation profile with prothrombin time, or the INR, international normalized ratio, or activated partial thromboplastin time. All these kinds of investigations you will have to undertake in addition to the specialized tests like Mycetism test, which is done on stool or gastric sample, small quantity of which you dilute with methanol, then you centrifuge and filter, and 1 to 2 drops on filter paper. You add concentrated hydrochloric acid. If you get a blue color, it is positive. Related test is Melzer test, which is done on spores obtained from the mushroom. So you have to have a sample of the mushroom, and this is stained with 1 drop of Melzer reagent, and then examined under the microscope. If the spores take a bluish black color, it is positive. So these are two specialized tests that you need to remember, the Mycetism test and the Melzer test. Aside from that, you can try and find out the presence of the toxin with the usual methods in toxicology like high performance liquid chromatography or HPLC. You can even try TLC, thin layer chromatography or radioimmunoassay. And you can do the testing on samples like gastric aspirate, serum, urine, stool, and in the case of a dead body, you can undertake liver and kidney biopsy and examine that also. This is the complete profile of testing that can be done in suspected mushroom poisoning. With regard to treatment, first of all, stabilize the patient with the fluid resuscitation. Remember, there can be severe gastroenteritis. Electrolyte correction should be done. If there is hypoglycemia, the usual measures like 10% dextrose. Metabolic acidosis should be tackled with sodium bicarbonate. Hypokalemia with potassium chloride. Coagulopathy, you can use fresh frozen plasma, injection vitamin K. If there is hemodialysis, if there is renal failure, you can undertake hemodialysis. And if there is cerebral edema, injection mannitol, and seizures, you can counter by the usual measures, including barbiturates like thiopentone. With regard to decontamination, if you see the patient in time, you can do a stomach wash, that is within up to 1 or 2 hours of ingestion, maximum 3 hours. You can even undertake activated charcoal. Some toxicologists say that it is useful, and some of them even advocate what is called multiple dose activated charcoal or MDAC. Forced diuresis have also been recommended by some toxicologists. In the first 48 hours, you can give up to 6 to 9 liters of fluid per day. Charcoal plasma perfusion is said to be useful, as also continuous veno-venous hemofiltration or CVVH. Hemodialysis, if renal failure occurs, and there is a specialized technique called MARS, which is said to be useful in severe mushroom poisoning, that is extracorporeal purification using molecular absorbent regenerating system. So what is MARS? It's a method of removing protein-bound substances from blood and is especially indicated in liver failure and hepatic encephalopathy. There is an albumin-impregnated, highly permeable dialyzer with albumin-containing dialysate, charcoal cartridge, anion exchange resin absorber, and conventional hemodialysis membrane. Molecular absorbent regenerating system of MARS is said to be really useful in severe cases of mushroom poisoning. But do remember, there is no specific antidote for mushrooms, though there are books which mention these drugs like injection penicillin G, N-acetylcysteine, and something called silibinin. Some of them go to the extent of saying that these can be antidotal in effect, which is not really true. Like for instance, in the case of penicillin G, which is given in or advocated in Amanita poisoning, mode of action is said to be displacement of amanitin from binding to plasma proteins, thus promoting the excretion and preventing hepatic uptake. We are not very sure whether it really is efficacious. You have sodium or potassium salt of penicillin G, which is used very commonly, and the route is continuous intravenous administration. The dose that is recommended is about 1 million units per kg first day, followed by 0.5 million over the next 2 days. I really am not very sure whether this is very effective, but several books do mention penicillin G almost like as if it's an antidote, which is disputed by many other toxicologists. Similar is the case with N-acetylcysteine. No doubt it's a hepatoprotectant, it's used in so many situations, and the hope is that it can prevent hepatic injury and insult even in Amanita poisoning by acting as a free radical scavenger, but we are not very sure as to how effective it is. There is no harm in trying it out, but if you do so, you should be starting it early in the gastrointestinal phase itself, otherwise it becomes virtually useless. And finally, silibinin is a silimarin derivative which is also a hepatoprotective. It competes with amatoxin transmembrane transport and inhibits amatoxin penetration into hepatocytes. It also inhibits lipid peroxidation and enhances glucuronidation. The dosage 20 to 50 milligram per kg per day intravenously. You also have tablets 70 mg and 140 mg, which is in fact what is recommended in India, because the intravenous form is generally not available. But again, a lot of controversy with regard to siliberin, whether it's really effective or not in preventing liver damage. If it's a severe case and the patient is going into complications, maybe you can try these measures as life-saving measures. And if a patient dies of mushroom poisoning, these are the features that you should look for at autopsy. Signs of icterus, hepatomegaly, hepatic necrosis, hemorrhages may be present over the surface of organs, petechia in the heart, nothing really specific, but these are the usual postmortem findings in Amanita-related death. Then there is a second kind of mushroom poisoning which is fairly common, Amanita muscaria, which does not behave like Amanita phalloides. It causes what is called muscarinic toxicity, and if you look at the clinical picture, it resembles organophosphorus compound poisoning. You have exhaustion with irritability, muscle cramping, and then salivation, sweating, lacrimation, frothing at the mouth and nose, with bronchoria, cough, wheeze, tachypnea, bradycardia, hypotension, vomiting, diarrhea, blurring of vision. Almost all these you will recall are seen in organophosphorus or carbamate insecticide poisoning. So the antidote, not very surprisingly, is atropine. You can give injection atropine sulfate as an antidote for Amanita muscaria poisoning, but not really Amanita phalloides. And with regard to medical legal importance, most cases are accidental. A few cases have been reported which are suicidal or even homicidal, but more than 90% of the time it is accidental ingestion, because somebody has rashly or negligently eaten a wild mushroom under the belief that it is edible, and then it turned out to be poisonous. So on this slide I have listed some precautions to prevent this kind of mushroom poisoning. Eat mushrooms which are wild mushrooms only after confirmed identification, and it's a known edible kind. As far as possible, eat only a small amount, and do not certainly eat it raw. Cook it well, and the mushroom itself should have been in fresh and good condition, not something stale. And don't mix up various kinds of mushrooms. Eat only one kind at a time. These are some precautions to prevent mushroom poisoning. While I've already emphasized this, mushroom poisoning may not be very common in India. It does happen. It does get reported from time to time, and there are always problems of misidentification. As you can see here, Amanita phalloides and Amanita caesarea. One is deadly, poisonous, the other is edible, and they unfortunately look quite similar. And remember that even if you come across a poisonous mushroom, if you think that you can detoxify it by cooking or freezing or whatever, it doesn't happen. The toxin will not be destroyed. So the key is to be careful while eating wild mushrooms. Having said that, there are a number of myths about mushrooms. So let us take a look at some of the common myths. Myth number one, mushroom poisoning is very common. Not true, certainly not in India, but that doesn't mean we should be complacent. Myth number two, if you eat a poisonous mushroom, say your prayers because death is only a few minutes away. Not at all. Many a time, the patient recovers completely, and if effective treatment is given within the proper time, recovery is 100%. Myth number three, if you eat a poisonous mushroom, you are as good as dead. We have already dealt with under myth number two, not at all true. Myth number four, if you get mushroom poisoning, you have to get the antidote immediately. As we have already seen, most of the mushroom poisoning cases, there is no antidote except for Amanita muscaria, perhaps, where you can give atropine. In all the other cases, though, there are some drugs being advocated as antidotes. They are not really antidotal in action. Myth number five, if there are animal nibble marks on a mushroom, it means it is edible. Not true. There are several animals, including rabbits and other kinds of creatures, which can eat toxic mushrooms without suffering any ill effects. But if the same mushroom is eaten by a human being, he can be seriously poisoned. So even if there are nibble marks on a mushroom, does not mean that it is necessarily edible. Myth number six, if I eat a little bit, wait for a while and do not get sick, mushroom is safe. Not at all. You have seen There are some mushrooms where there is a lag phase which can extend up to 24 hours. 24 hours, nothing seems to happen. Only after that manifestations begin. So because of this, you can never be safe, and you cannot follow this rule at all. Myth number 7, if you cook a poisonous mushroom thoroughly, it is safe to eat. We have already dealt with that also. Even if you cook or boil or fry or whatever it is, a mushroom thoroughly, toxins may not be destroyed if it is a poisonous mushroom. So some safety tips on mushrooms. A mushroom is likely to be poisonous if you see these features, like for instance the gills, the undersurface of the cap are white. Any other color, no problem, but white can be poisonous. And the cap is bright red, like I've shown you one image, that can also mean it is a poisonous mushroom. If there is a ring or annulus around the stipe or stalk, or if there is a wall by the base, or when you cut the mushroom and there is a bad odor, all these are signs of a poisonous mushroom, and you have to be extra careful. So remember the old adage, the old saying, which goes, there are old mushroom hunters and there are bold mushroom hunters, but there are no old, bold mushroom hunters. Very important to remember. If you are in the habit of foraging in the countryside for wild mushrooms, remember you have to be very, very careful. In that case, you will grow old and still go about hunting. But if you are rash or negligent, what is termed as a bold mushroom hunter, you may not live long, because sooner or later you will come across some poisonous mushroom and die. And that is why it is said that there are no old, bold mushroom hunters. You have to be really careful when you are going foraging in the countryside for wild mushrooms. So that is all from me, from Dr. Somnath Das, who made this very interesting kind of presentation on mushroom poisoning. Thank you very much. And goodbye from the Indian Society of Toxicology. We will meet again on some other episode when we take up something else, some other poison. Do subscribe to the channel and click on the bell icon for notifications. We will be uploading such interesting and educative videos from time to time, usually once or twice a week. Goodbye and all the best.